So I'd like to thank you for inviting me to speak today at the SOMA forum. I'm disappointed I wasn't able to be there in person, but very looking forward to the discussion of the Q&A soon, and the sessions so far have been great. So I've been asked to talk today on the intersection of research and surgical training. My name's Ian Incoll, and I'd like to begin by acknowledging the traditional owners of the lands on which we meet. For me, it's the Darkinjung people, and I'd like to acknowledge their elders past, present and emerging. My declaration of interests, particularly relevant to this presentation, is that I teach on the graduate programs in surgical education course at RACS and University of Melbourne. And I've also been the chair of training and the dean of education at AOA for about a 10-year period, and was heavily involved in the development of the new orthopaedic training program, AOA 21. So I've been asked to talk about the intersection of research and training. And really most of the training programs have a minimum research requirement during their training, and it's usually part of being able to sit an exam at the end of training or to be completed before certification as a surgeon. Most of the programs have for many years included the requirement to submit a research project proposal, usually fairly early on in training. And also that would need to be seen by the training board, the outcomes of that project, and to be signed off and approved. This signing off process is often not very clearly regulated, not clearly defined. And so it can sometimes lead to projects being signed off which really are not completed or of a relevant standard. Often the requirements for training boards would be that they need at least a national level meeting. And this can often be a subspecialty meeting as well as the actual specialties meeting. And you'll see there a publication from last century that was my research project during orthopaedic training. So why do we demand research within the surgical training programs? Excuse me. I guess there's a number of different reasons, and one certainly is to try and provide research literacy in every surgeon coming out of a training program, so that they can actually look at the evidence in an article or publication. They can assess the merits of that publication and use that knowledge to incorporate it into their own practice or not. I guess another reason to have research as a mandatory part of training is that it embeds the importance and highlights the importance of research for our specialties and also for the improvement of patient care. Looking at it from an educator's point of view, it's one of the things that is fairly easily measurable and accessible. A research project is something we can look at the quality of, we'll look at where it's been published. And so it's an easy way to assess a completion of a component of training. Probably more importantly is that it actually helps to establish research habits in a trainee that would then hopefully continue on during their working life. It may not lead to research output, but at least it would encourage the examination of your own treatment choices, your own treatment outcomes in a more scientific manner. Another reason why it's probably there is that it does benefit to some extent those who invest their own time in training. So the surgeons themselves, if they have a research project done that they're involved with, get a publication or presentation, that helps, one, to meet their ongoing continuing medical education requirements, but also helps to raise their standing in their own peer group community. And lastly, but definitely not leastly, you would hope that most of the research that is done will ultimately lead to improvements in patient care. It may not be immediately, but the good research projects will eventually change care or improve an aspect of care. So just wanted to talk a little bit now about the AOA 21 program. And we spent, a committee of many people spent many months working on how we were going to improve our research requirements for training. And so I'll just talk you through that over the next few slides. So AOA 21 has also been adopted in New Zealand and is being looked at by Finland. And in the AOA 21 program requirements for research, there's three major pathways. Collaboration is encouraged, whereas in the past, a lot of the research programs are done by an individual trainee, and by necessity, these were often smaller projects with less value in their outcomes. We also really wanted to highlight this and support trainees who were considering becoming academic surgeons, so surgeon scientists, and you'll see the PhD pathway there, which I'll talk about in a minute. Also, we actually were being a bit unfair on some trainees that had done previous research, and so now if you've come into the training program with a PhD or higher education in a research type field that's relevant to orthopedics, that may well be enough to complete your research requirements. So we don't get people to redo another PhD or more research when they're obviously already have that knowledge and abilities. And another thing that we changed from the previous AOA training program was that the research requirements only really have to be completed by the end of the transition to practice phase, and that is then required to be able to be signed off for registration. So our fellowship exam now is more towards the middle of training, and so the aim is to allow people some time in their final year to actually complete their research, and hopefully by doing that get a higher standard of research output. So the project pathway is really the standard way we've done things in the past, but it does need to be part of a major research project. As I say, there can be collaboration. And because we move our trainees every 6 months, we like to have a central supervisor that provides the continuity for the trainees that are collaborating for that particular project. And it must be directly relevant to orthopedic surgery. So more novel, so part of the project pathway is that it requires collaboration, often because they are big projects, often can be multi-center projects. And a meaningful contribution to the project would probably require at least 2 of these components of research output. It needs to be developed to a publishable standard, although it may not necessarily have to be published as yet. We know that sometimes it does take a long time to get papers published, and that's assessed by a separate federal review panel. It must be presented at a national meeting of some sort, so either at the AOA meeting or subspecialty national meetings or international meetings of a minimum standard. So we go on to do the coursework pathway. The coursework pathway, the aim of this is to improve knowledge in research literacy and the understanding of research output. And it usually is a graduate certificate or a graduate diploma, usually 1-year part-time course. And it must include a minimum of 2 of those subjects so that it really does give a good grounding in research methodology, epidemiology and biostatistics. It needs to be pre-approved, so the trainees submit the course that they want to complete with its curriculum, and then that is assessed by the AOA before approval. And also part of that coursework pathway is the trainees would also need to also take part in a small project of one sort or another. Again, it can be a collaborative effort, and it needs the output of that part of the pathway would be assessed by a regional review panel. Now, the PhD pathway is something new, and it exists because we want to encourage the surgeon scientists that might be coming through training. We've looked at the major academic research centres around the country in orthopaedics and asked them to establish training posts that are flexible and that also have established PhD supervision records. The trainee would apply to the hospital fairly early on in training, usually within their first year of training, to undertake the PhD. And the aim is during their training, for at least a 2-year period, they would work half the time on their PhD and half the time continuing their clinical load, maintaining and improving their clinical skills. So the aim is not to have them de-skilled by doing a PhD full time. And as I said before, the aim is for them to complete that PhD by the end of their transition to practice before registration. However, we have had a couple of trainees that have their PhD has run over and they've done it during their fellowship time. And I don't think there's any problem from the AOA's point of view regarding that, but it would be on an application, but on a case-by-case basis. So what research is good research? I sort of asked myself this question when I was looking at this, the intersection of research and training. We obviously want to encourage useful research. We don't want to encourage a case series of 10 knee replacements, for example. So we want our trainees to be putting in an effort in research that actually will provide outcomes. And so these are just some of the points that I've come up with to what makes good research. And I think most importantly, it examines a relevant question to that particular trainee or that particular hospital or that particular surgeon in a way that potentially can answer the questions. But if not, if there's good methodology, it can then, if it doesn't provide answers, can lead to further questions. I guess another important part of good research would be it develops knowledge where there are currently gaps in the knowledge. And I put down qualitative work there because qualitative work often will lead to a better understanding in areas where at the moment it's grey. Quantitative research, we tend to look at an input and its effect on an outcome and look whether the change in the input improves an outcome. Qualitative work is done to understand why things happen. And so really would encourage people to look at qualitative work. I know there's a talk later on today about qualitative research, but it's very important. And the idea of research in general is to help move our current estimations or assumptions that we have at the moment towards what is actually true or what is actually occurring. You'd hope that research is mostly directed to improving patient outcomes. And I've also put value there because we are more and more worried about our limited healthcare budget. And so if we can improve outcomes and reduce costs, then the research is of use or value. And finally, I think some of the best research happening now is the work that challenges the prevailing dogma. So, for example, in orthopedics, some of the sham surgery trials that have helped us understand that knee arthroscopy in over 50-year-olds really is not of any benefit at all. But it did require those kinds of studies to demonstrate to surgeons that the value of knee arthroscopy in arthritic knees, and also to change their practice. So well-designed research will change practice, stop unnecessary surgery or low-value surgery. So the vast majority of research that's done in training is clinical research. It looks at outcomes for patients from treatments often. Another group of research that's done during surgical training is the basic science stuff, and this would be mainly, excuse me, those undertaking PhDs, and we know that there's a few of our trainees that are currently working on things like cell clotting or bone substitutes or in fact bone printing. But I wanted to also highlight that there are other areas of research that are just as useful, just as valid, and wanted to sort of talk about these two areas: surgical education research and quality and safety. At the moment, there are very few research projects done by trainees that involve these two areas. So just by way of an example, we looked at our selection process and also our assessment process in orthopedic training, and examined whether this statement from 2001 was correct: the low percentage of females is not due to bias against female applicants in the review stages of the orthopedic selection process. And so we looked at that and developed or looked at the selection process and our assessment process. We presented that paper at the Canadian International Conference on Residency Education and came away with the Best Paper Award for that. So certainly research into surgical education can meet your requirements and can help your careers. So in that study, we looked at lots of different measures and came up with a consistent theme that female gendered applicants were less likely to be offered interview, and also during training that there was decreased autonomy for trainees during operative procedures. And I'd like to thank my co-authors for that study. In another body of work, and Chris Conyard there, the final author, did this during his training program. So this formed his research project during training. Is we surveyed the orthopedic trainees regarding their perspectives on informed consent. And in general terms, we asked them about their ability to provide it, their knowledge of it. And overall, they felt very confident that they were able to obtain informed consent in a legally and ethically valid way. Unfortunately, when we broke that down into the components that we know are important in ethically and legally valid informed consent, we found that many times they were not undertaking those particular aspects of the process. And so it was a nice way of discovering that their perspectives did not match reality, I guess. And what that's led to, that and another study have led to development, mainly by Jodie Atkin, of this informed consent teaching tool. So it's both a teaching tool and an assessment tool that's been developed out of this part of the research project. And I mentioned about quality and safety before, and I just wanted to point out some of the work that we've done at my hospital in quality and safety. And there are very clear, easy to use guidelines produced by the Squire Group on how to undertake and particularly how to publish or present quality improvement work. And I'm sure that many of you have done some quality improvement work at your hospitals already. Please keep considering how you're going to get that out to presentation and publication, because it is a work that's often you're doing, but then you're not getting the benefit of actually putting it into a publication. And this is just one of the works that we've done, one of the works we've done at my local hospital on restricted weight bearing. So thank you, and I look forward to the Q&A panel session shortly.